overdoses. And this is, I've been in the business for 40 years around substance abuse and behavioral health, and this is easily the most serious crisis I've seen by a long shot. And people are dying. A lot of people are dying. And I'm also concerned about, we've done a great job of putting out Narcan and reviving people, but each overdose is roughly equivalent to a concussion. And we have routinely people coming in with 20 overdoses in their history. You get 20 concussions in your history, and we got some long-term brain damage, right? So we're worried about that long-term consequence. As Commissioner Dare was saying before, the consequences with neonatal abstinence syndrome and people ending up in NICU for babies is incredibly serious, and so long-term birth defects are going to be very, very common. I was on the Maternal Mortality and Morbidity Review Committee for the state for 4 years, and where we reviewed every single maternal death that occurred in the state, did a deep dive into the clinical consequences. Over half of those deaths were drug-related. Those are only going up dramatically. So these are long-term consequences, and we already have an affordability problem with housing, and so homelessness and very, very cheap fentanyl is a toxic mix, right? So,
Rick, would you mind sharing the numbers that you shared with me at the Health Council meeting? Can you do that? Your deaths this year to date?
Oh yeah. So they've gone up since we talked. So we've had in my agency, whenever we have a client death, we have a sentinel event debrief about that death, and so that's led by myself and the chief medical officer, and that used to be like a once a year event. Like we'd have to pull out the policies and procedures and how do we do this again? And we've had 19.
Two more since we talked at the Health Council meeting then. 19
this calendar year. I don't have to pull out the policies and procedures anymore. I've just never seen anything like this. So that's the long and short of it, is that if we didn't have the burn, we'd have to invent it. So I wasn't a big supporter of Measure 110. I actually voted against it because I thought you should actually set up the system, then change the legality around it. But that's not what they did, and of course nobody cares what I vote for. But if we didn't have this, we'd have to set it up. Okay. So what we've done, why don't we go to the next one? Keep your day job.
Yeah. And Brenda, Healing Rains, it's R-E-I-N-S. Yeah.
Yeah.
Wow.
So what we did at the start of this, all before fentanyl, mind you, is we set up a network of providers, and we got 6 of them, and yes, we have 6 of them, and that is the network of services that is provided. So that's where Shields County, Healing Rains, Ideal Options, Boulder Care, Rock Trails. What we're trying to do, this is a model that went back 20 years, 20 years, called the recovery management model. I remember having a long conversation with the guy who developed it, and it's a looking at addiction as a chronic disorder, very similar to diabetes. And so you really need outreach, harm reduction, on-demand treatment, and long-term recovery supports if you're going to have an impact. And on-demand treatment access, I remember the first clinical gem I got in my first job as a volunteer at the Lane County Council on Alcoholism is strike when the iron is hot. Even more valid now than it was 40 years ago. So, what we did set up is the Taylor Center. And so each burn is supposed to have a rapid access, immediate access, low barrier access to services. So we set up the Taylor Center is our burn. So Barrett runs that, and then Christina is our burn coordinator and works with the network of agencies. So what we can be here and Barrett can present about the Taylor Center, any questions you have about it in detail, rapid access to treatment, rapid access to medication supported recovery, and basically walk-in capacity for that. And just because you're civilians, medication supported recovery for people with opiate addiction and certainly with fentanyl. So the thing with fentanyl, people are, so traditionally we've had heroin addicts. Those are well studied and well understood. And your level of dependency is going to be X amount. And we talk about them in terms of methadone equivalents. And so your classic heroin addict, you could start on methadone at 200 milligrams, up to 400 milligrams as they're deep into the pool. Fentanyl addicts are blowing past that. And we're getting people more addicted, more dependent than we've ever seen before. And without the medication to support that recovery, actually did a study when we flipped over to doing medication supported recovery about 5-6 years ago. And before we introduced medication supported recovery, their opiate addicts' chances of staying engaged in treatment was 1/10 that of meth addicts. And I don't know if you've been around active meth addicts, but they're nuts. And so it's like, if you can't beat a meth addict, you're in trouble. Just observation. And but with the introduction of medication, their engagement rates were right up with the other addict alcohol. So this is like, at this point, it's unethical to offer treatment without rapid access to medication supported recovery. Just the differences are stark and life and death. Naloxone supplies, needle exchange, employment counseling, housing vouchers, household supplies, outreach peer services, and expungement of your record. That's me too. Am I missing anything? You do a lot. And Christina's set up. Go ahead. Also, best care. Yes, sir.
Could you talk about harm reduction and what's the strategy and how it fits in with this model?
Sure. And there's a range of what harm reduction means. So I think some of what gets confusing is how we define harm reduction. Okay. So I'll start at a really basic level and get a little further out. But the basic principle is you don't get into recovery if you're dead. And that's what it's really come down to us for now for us, because you know, the death rates we see just in our clients, and that's a lot lower than what we're seeing on the street. So, and the strategy is that basically that we can keep engaged with you long enough that we can develop a relationship and ultimately move that person into recovery, hopefully. And sometimes you have to chase people a long time. Okay, so the idea is start where the client is, but don't leave them there. Right, and so various forms of harm reduction that one of the things we had to do is at first, you know, 2 years ago, if you entered our addiction medicine clinic, we got you on medication and that helped with your opiate use, but you're still out there, as we call it, ripping and running on alcohol and meth. We would eventually have a come to Jesus meeting with you and say, okay, you're not ready, we'll take you off the medication. Well, with fentanyl, people died. I mean, we were having people die 2 weeks later of an overdose. So we can't do that. And so these people aren't ready for a regular treatment group with people who are really trying to get clean and sober and do something with it. But we dare not take them off the medication either. And so we had to develop a whole different arm of treatment that was really able to accept people who we were still engaging with, and we ultimately had a goal for them to enter treatment, but they weren't ready yet. Okay. Then a lot of what Derek does is he goes out in the van and starts engaging people, homeless people, making sure they have supplies, they have naloxone, they have clean needles, they have, etc. And a lot of that is to create a relationship, because what we've seen in any setting, in any way you go about it, entering recovery is about relationship. And even if you take, this is what gets missed, even if you take a straight sort of drug court law enforcement approach to treatment, all that's doing is slowing people down enough so they can develop the relationships and trust and enter into recovery. What we found with our outreach services is that those are working also. And actually our referrals into our addiction medicine clinic have tripled in the last year. And those are good referrals. So those are people who are sticking. And our referrals into our outpatient services has doubled in the last year. So whether that is, you know, demand is going up, but also these engagement activities are having an impact. So basically the core idea is to work with people. You can't get into recovery if you're dead. And start engaging them with where they're at, not where you want them to be, but keep engaging them, working to get them into long-term recovery. Okay, so housing, thank you. So we've been able in Deschutes County to set up 2 houses for recovery. We decided to go to niches that weren't being built right now. And so one was a house specifically for pregnant women and women with new babies. That's a big deal for me. Policy I've been pursuing for 10 years. And then we set up a recovery house specifically for people on medication supported recovery, because there wasn't one. And Christina themselves. Okay. Any other questions for the overall picture or for either of my staff?
So are you saying, this one house for pregnant and new babies, that we've had 6 fentanyl babies born in the last 70 days at St. Charles?
Yeah.
Are you saying that those babies are gonna stay with their mothers?
So we have a Nurture Oregon program here in Deschutes County. We run it, and we've run it for quite a number of years. And so that program is specifically aimed at outreach to pregnant women who are using drugs. And we specialize in women who are using IV drugs. And so when you look at that population, they're the most stigmatized population you can pretty much imagine. They know they're stigmatized. They fear child welfare taking their babies away at the birthing center. They've often lost children before. They're often in terrible, terrible circumstances, almost pregnant, using fentanyl in abusive situations. And so we set up a team of women who used to be those women. They've all had that experience. They've all been using drugs. Many of them have lost their children, regained them later. And they can do magic stuff that no one else can do. And so we have relationships with the OBGYN and primary care clinics, clinics who see these women. And we can get them rapid access into OBGYN. We provide housing. We've been doing this outreach engagement stuff for years with this population, and we're able to engage over 50% of the women that we come in contact with. And they get clean and sober, and they take their babies home. And it's like, it's really, really an amazing program. And the one I'm probably proudest of the organization. And you get to know them, and it's like, it brings, I'm an old crusty guy. I don't get emotional about anything but this program. It just brings tears to my eyes. It's a good one. So if they were engaged in the mom's program, we have a pretty good chance that they'll be able to go home.
But I mean, the complications of fentanyl babies, according to this study out of Delaware, is unbelievable.
And so if they deliver on fentanyl, high doses of fentanyl, we have problems. What we're able to do is flip them over to, we've got them into medication that reduces dramatically the risk of a neonatal abstinence syndrome. And dramatically reduces the probability of any birth defects. So if we can intervene relatively early, we have a good chance. But if not, the consequences are pretty devastating.
I thought they were incredibly devastating. From what I was reading.
Yeah, and society tends to just turn a blind eye to that, but it's an expense we all carry.
Well, right. What's going to cost that child?
Yeah, even if you don't look at it from what's the right thing to do, which you should. But what's the economically advantageous thing to do? It's where both money and morals go together.
Well, I heard this story the other day about a couple in their own home in Redmond that couldn't stop doing fentanyl, and they had their 3-year-old in bed with them. And so DHS came in and got all the kids. So it's such a powerful addiction. How many kids are being taken from their families now? Right. What are those numbers?
And we know that child welfare is a fairly destabilized agency, really high turnover. Staff is burned out already. So you're not going into a well-functioning system. So this is really important stuff, and I can't emphasize this enough. This has been a game changer. I don't think it's caused by Measure 110, but I think Measure 110 has come along at the right time. I chance.
Questions after the presentation, but one I have kind of I could ask right now would be, this wonderful network of organizations that are doing this work in our community. How did you get identified as the burn providers? Did you apply to be part of the burn, or did the state like ask you, or both, or how does the burn get?
Everyone applied. It was an open process, and who are the interested people? And basically, Janice Garceau and I were talking, and let's get this going. And then it was an open process, and then we all talked about what's the best way for us to work together. And the great thing about working here in Central Oregon is everyone plays well in the sandbox. And so I've been really clear, Best Care runs easily the largest substance use disorder system in the region, but I'm really clear that I'm not in competition with anybody. We need to make the market bigger, not compete with each other on a market that's too small. I mean, to put it in those terms, it's like, and so what happened, the clinicians just support each other across the system.
And I think when you see the presentations, you'll really see that each organization carries its own niche and complement each other as we do this work. And there's not redundancies and overlap, but really an expansion of services across the continuum, which I think makes our burn really unique.
Yeah. Okay.
Thanks.
Well, again, I'm Lisa Bradley with Healing Rains. I'm the clinical manager at Healing Rains. We offer mental health services with the inclusion of equine. We also offer adaptive horsemanship and equine assisted learning. So they're all very similar and a little bit different as well. But here we're focusing mostly on equine assisted learning for our substance use disorder treatment groups, which is our part of the burn, is that we were given the opportunity to offer these groups and individual services if we felt the need, which we have offered individual services as well, but are trying mostly to grow the group aspect. I think having groups of individuals helps with that universality and learning from one another, and can kind of really target a lot of things at that time as well. So equine assisted mental health is really mental health services with the inclusion of equines. The inclusion of those equines are there to enhance the treatment goals that the therapist is putting out with the client, in conjunction with the client. And it's also there to support the evidence-based modalities that these counselors come in with. So we are doing mental health counseling and then enhancing those processes with the equines. So things that the equines might enhance are ways that we set or do not set boundaries, the way we feel safe or do not feel safe, the way that we attach or connect with others. So sometimes, and it also offers a alternative to the traditional therapy office, which oftentimes people who are seeking services or who aren't seeking services don't want to seek services because they don't want to sit in front of the counselor in a room and be the vulnerable subject, right? That's hard. So to offer outside services where you can feel the sun on your skin and hear the birds and things like that, that might be a little bit more attractive to people. It also offers something for people to do or interact with. So there's a really wonderful embodied or body focused sort of place that comes in, which allows for better healing, in my opinion, as a counselor. Because you're reaching more of the whole person, not just the stories, but also how your body is attached to those stories. A lot of people that are using substances tend to use them to self-medicate their things. They don't want to feel, so they're numbing their bodies. These are things that I've heard from clients. So, horses, I said a little bit about how they are unique to these services. We tend to project things that have happened to us onto these horses. This horse doesn't like me, blah, 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 even though the horse is just eating hay, they're doing their thing. Those stories are what is important because they're coming from that person's experience. So they do highlight a way that we can get to material. It also is an assessment tool. They tend to read our vital signs because of horses. They sort of sense the environment a mile out, so they either reflect our anxieties or they lower their own heart rates to support us to lower ours. So they offer also this biofeedback mechanism. So our groups are geared towards, well, I approach them in a way of I'm always trying to help people become more aware of the patterns and things that we operate from. It's easy to just do our routines and go through our lives and make choices based off of things because that's what we've always done. But what happens when we bring awareness to our choices and when we make different choices? And that's sort of the question. So my hope is that as I invite topics like safety and keeping ourselves safe, or how we set boundaries or not set boundaries, that they get to go, oh, this is my experience. This is why I started doing this. And maybe I want to change that. We learn basic horse skills, and in those basic horse skills, you kind of see how people approach different situations. They might choose not to want to dive in, or they might fully dive in. And those, again, are more awarenesses about who they are and how they approach the world and how they approach other beings. When a horse sees them, how does that feel? Because maybe many people in their life have not seen them. Or if the horse does not seemingly see them, what does that bring up to that person, and how can they work with that material? It creates, I did say something about the sort of alternative space of being outside.
So how many people are you working with then in this program?
Yeah, so far we have served 21 individuals, which I believe.
Don't you work with like almost 200 on a monthly basis or something?
Yes, our whole
video.
Yes, our whole services has expanded quite a bit. We have 6 different therapists that work for us at Healing Reins, offering equine assisted mental health. And so we see, I think it was over 200, or
it was 194, I remember.
Yeah. I don't actually know the number off the top of my head. I apologize. But yes, we see quite a few individuals, and we are in the process of growing that. We'd like to build an intern program as well, so that interns from OSU or people who are becoming counselors can learn this as well. And it's also a very important, it's not its own modality. Equine assisted mental health is not an evidence-based modality. We are using evidence-based modalities such as CBT or DBT with the inclusion of horses. And to include those horses takes a certain skill set. So it's a little harder to hire therapists or look for those right ones, but we're trying to support a growing of that so that we can continue to serve more individuals. And then, of course, we'd like to grow our substance use disorder treatment groups as well. We've begun making, one of the barriers has been staffing. Yeah, thank you. One of the barriers has been staffing. We've actually supported 4 of our staff to be trained as peer support specialists, which is great to have in general. But what happened is they were also busy doing our other services. So we found that the amount of groups that we could offer was limited. And so we ended up hiring somebody specifically and have trained her as a peer support specialist, or she's been trained as a peer support specialist. And she'll be taking on the majority of these groups with me, so that that actually opens up a lot more space and time to offer more groups. I also think that getting the word out there has been a little difficult. I think it does take a lot for an individual to decide on their own to go into services. So I feel making relationships with other agencies who already have the clients in their spaces to make that connection and bring them out would also be really helpful in expanding those services. I feel like that's about all I have. So
Great.
Any questions?
Any other questions?
Thank you.
So how many horses work with the group
Anywhere between 3 and 6
at a time?
Yes.
Hello, everyone. My name is Sarah Love Sanderson. I'm the community liaison with Boulder Care. We are not based in Deschutes County. We are based in Portland, Oregon. So as a community liaison, I work throughout the state of Oregon. This is only my second time to Deschutes County, so excited to be here. Boulder Care, we provide telehealth treatment, medicated assisted treatment for both opioid use disorder and alcohol use disorder. This is done through a proprietary app, through a tablet or a phone. We have served over 2,500 Oregonians since 2019 when we first started seeing patients. And we started pre-pandemic, we are on telehealth, with the intention of only being telehealth. We had no intention of being a brick and mortar, really to reach people in the more rural areas that don't have access to treatment or have barriers to traditional residential or intensive outpatient treatment. We provide low barrier harm reduction based treatment. What that means to us, we are non-punitive. No one gets exited from care for return to use or use of other substances. There's no 3 strikes you're out rule with us. We have a care team model that consists of clinicians, registered nurses, peer support, case management, and care advocates. Care advocates work like a medical assistant in a brick and mortar, where they work through issues with pharmacies and insurance. We have Measure 110 funding in Deschutes County. We also have Measure 110 funding in 8 other counties.
Or is that the 40.41 million, almost $500,000 then?
We did not get that much. Yeah,
I mean, that's what's on this chart.
$500,000.
Yeah, it says 0.41 million on the chart.
That was attached.
Oh, okay.
Different funding mechanisms for each.
Okay, I apologize. I'll have to double check with that number, but I know we do have funding in Deschutes County. If that's the number that it says, then my understanding it wasn't that much, but
We'll find that number.
Absolutely, yes. So some of the barriers in Deschutes County is that the Measure 110 funding does cover cost of care, but it does not cover medication. We currently are not partnered with Pacific Source, which is the CCO in Deschutes County, which would cover the cost of medication. So that is a barrier to engagement. And we are growing our community liaison presence. Currently, I am the only one. I started back in May of this year, but we are presently in the process of hiring another community liaison. So we have served 7 residents of Deschutes County for the second quarter of 2023, 6 for quarter 3. What we are looking to do is work with our community partners on providing technology assistance, as in telephones and tablets. So we just purchased 15 telephones that are being delivered today. So we will work with community partners to get those in their hands. We are also looking to expand our outreach with community liaisons. The community liaison we're hiring is specifically for Southern Oregon, which I have been working in the last 6 months. So I can focus more on Northern Oregon, the frontier counties, and Deschutes County. And working with Pacific Source to partner with us so we can get prescriptions covered through that CCO. That's about it. Yeah, any questions for me aside from,
Right.
yeah.
Thank you, Sarah.
All right, thank you.
So Holly Harris with Deschutes County Behavioral Health. So as you all know, as the community mental health program, we really are the safety net provider, often tasked with crisis services, homeless outreach, harm reduction, criminal justice diversion. So that's really where, as the burn partner, we focus our efforts to be we're oftentimes the first point of entry for people struggling with substance use disorder, co-occurring disorders to enter into the system. So it's a great opportunity to expand those services, to be able to have easier access for people who are willing, ready to engage, but also those who come into crisis services who don't even know that they're ready to, needing services, but we're there 24 hours a day to be able to offer support when they need it at that, when the iron's hot, as Rick mentioned earlier. So with our burn dollars, we added 4 peer support specialists to the stabilization center for after hours operations. Really specifically, the burn required 24/7 access. The Taylor Center is what's sort of our 7-day-a-week daytime hours operation, and the peers at the stabilization center provide that the rest of the after hours contacts. And so it's really important and critical that our agencies work together to be able to provide a seamless coordination for those individuals who come in after hours, who are maybe going to have ongoing support at the Taylor Center for drop-in services, that they able to act. We have, and these peers are also specialized training and substitute disorder treatment, so recovery mentors, that type of extra training. We also added peer support specialist and a case manager to the drop, which is, of course, our drop-in center for youth and young adults. So we wanted to make sure we were capturing that population as well. And then we added 6 FTE to our harm reduction and homeless outreach team. So these, as you all know, these are teams that are going out into the community, out to homeless camps, out to anywhere that people will have them to really start working on building rapport and engagement, so that then we can do warm handoffs to the other organizations that are in this room and really get them connected to services. In addition, we secured 4 shelter beds at the Bethlehem Inn for emergency temporary support for individuals served by our host, our homeless outreach team. So this was really a mechanism. We originally actually started off with 10 beds, and we pared it down to 4. There's challenges, obviously, with temporary emergency shelter. If you don't have a place for them to go after that, it can be pretty disruptive to their life, actually. So, but for some people who really just need a longer break than, say, what the stabilization center can even offer, maybe a couple of weeks of shelter, so that we can actually get them set up with some services and get them on the right track. It can be a really great like respite opportunity to get them stabilized and actually succeed more in our engagement efforts. So our data so far shows that we've served about 492 unique individuals with over 2,000 visits since starting our burn work. Stabilization center in particular, we know that about 40% of people who come to the stabilization center have a co-occurring mental health and substance use disorder that they've identified. 21%, and I believe this number to be quite low, but this is self-report, that they come under the influence at the time that they arrive at the stabilization center. We suspect that that is significantly higher than the data that we have. And the nice thing about the stabilization center, as you all know, is that, and having the peers there after hours, is that it's not just come in for crisis services and good luck, we hope you make it, here's an appointment or here's a referral. We actually work really hard to handhold, to walk beside them, to help them get to the place that we think is going to meet their needs. And so the warm handoffs are really a critical part of our burn, making sure that they're successful in getting to the place that they want to get to. Our harm reduction data, we believe this was shared just recently at the Behavioral Health Advisory Board as well. We've distributed about a little over 1,300 naloxone kits. There's more than one distribution of naloxone in a kit. And about 70% of people receiving naloxone have reported witnessing or experiencing an overdose. So we believe that these services are really important to make sure that we're reaching the people who may be interested or in need of these services, and then we work really hard to connect them with the ongoing supports that they need. Oh, and then we have a dashboard. This is just mostly just a snapshot, so you can see at the bottom, you can see the tabs. As a burn, we're all required to report to the state quite a bit of data each quarter. And that data sometimes changes, as we all know as burn partners, but it grows and grows and grows. But we continue to track that's, to our best ability, but we've created a dashboard at Behavioral Health to be able to take a snapshot at any given time of kind of the demographics of the population we're serving.
OJ never ask for less than.
Little surprise reporting, yes, as we like to call it.
Any questions for Holly?
Yes, your time.
Hi. Bear with me, I'm a little nervous.
Dopey. She comes through Yamhill County, is that right?
Yes.
And she has two daughters that live there.
I do.
Yeah. No, you should feel right at home.
Your level of memory amazes me and simultaneously makes me quite envious.
Don't, it's off some days.
I
really
don't have
badly.
that. It makes me very. So my name is Heather Doherty. I was stolen from Yamhill County, adult behavioral health, where I was, the chemical dependency lead and also Matt and problem gambling primary counselor out there. So, I've got about 6 years of, not 40, not 40. I took a lot of notes while you were talking. I didn't know that. But I got about 6 years experience in that, and I did, help in building the MAP program for buprenorphine and suburbane for Yamhill County. So, we've done a lot of really neat stuff out there, and I'm super excited to bring my knowledge and experience in this direction to help with Ideal Options. So with that, I've been with Ideal Option for about a month. So I took seasons, a lot of, yes, very seasoned. Yes. 4 weeks. 40 years. Yes. I took a lot of notes and some cheat sheets from Mr. Josh Blair, and I don't have the tattooed head, but I did put some blue in there so that way you can try to channel his energy. So Ideal Option is, well, there's some words up there about being a national leader in medication-assisted treatment. We do have about 90 outpatient clinics, and we have served over 70,000 patients, help them to start recovery. And we have over 250 physicians, nurse practitioners, physician assistants, lab professionals, and medical assistants. Okay, yes, we have quite the staff.
And you're in 11 states too.
Yes, we are in 11 states. And I actually oversee 12 facilities across Oregon and Southwest Washington for community outreach and the like. We are low barrier. We do evidence-based treatment for medication-assisted treatment. That includes alcohol use disorder, opiate use disorder, and then we also treat for hepatitis C and also stimulant use disorder. So we do offer quite a bit of different treatments. We offer outpatient services for medication assisted, and then we refer out for your standard chemical dependency or mental health treatments with our partners. So just these are folks who kind of be and we accept Medicaid, and we don't have wait lists. I think the longest wait that we have for an individual seeking treatment is 24 hours. We do our very best to get people in as quickly as humanly possible. That's one of the amazing things that I loved when I was interviewing Josh for this job.
Yeah, you're open Monday through Thursday, 10-hour days. So what if somebody comes, they hear about it Friday night? Do they have to wait until Monday? Is there any way anybody else in the room can help them?
We would,
So we have a 844-347 referral hotline for community partners. And within 90 seconds, someone's going to answer that phone and be able to get somebody an appointment. If not that day, within the next working day.
yes, and we will, I believe, help them.
Best care has the capacity for MAT, 24/7.
Answer. I got all the experts around me.
And we partner a lot with Ideal Options. There's
Yes,
political partnerships going back.
we can't, we will find the expert. This guy. We can't. I think we've heard it quite a bit today. MAP saves lives, and also increases the opportunity for people to get some time under their belt in a little bit of sanity so that they can learn those skills. for life, and work towards, long-term recovery. I think that's one of the things that I really like about Ideal Option. We will help with that medical stabilization so that people can kind of find their wits about them, put their feet underneath of them, and then move towards other areas. And now we'll get into our data. So in the last year, Ideal Option has served 765 unique individuals in Deschutes County. 110 has provided resources for us to conduct outreach to our individuals in Deschutes County and to our community partners. I don't think it says it in here, but it also enabled us to have Shonda, our peer support person. So, and then what is this? In the Deschutes County Jail, we have treated 49 people for substance use disorder. I think it's absolutely amazing. And then we work with all of these.
Let me just sort of jump there. There's a
Yeah.
movement happening, where we think, medication assisted treatment needs to be provided in all the jails across the state, because the risk of overdose death, multiplied by a factor of 27 upon release. And so, I would view what Ideal Options is doing in jail as just a appetizer for what really needs to get done.
Yes, I know there are some state facilities that are offering Sublocade at release, which is huge. And to speak to that, oftentimes an individual will go to jail, they'll detox if there isn't that medication offered within the jail. They'll be released from jail and they will go back to using in the same way that they were using before. They have a higher risk of overdose with heroin, and when you put fentanyl into the mix, that risk is I wouldn't call it a risk, I would call it inevitable.
Yeah, and none of us are predicting long-term fentanyl addicts. They just want to survive long enough. And just 2 weeks ago, I had a meeting with the Cook County Sheriff, Health County. And he was saying over half his inmates are coming in withdrawing cold turkey of fentanyl, which is fairly unsanitary prospect, dangerous. And so they're returning to use. And he was seeking medication assisted treatment in his jail. And I don't think the Cook County Sheriff is noted as being soft on crime, liberal kind of guy. Sheriff Gentry is fairly old school, but very practical. And he wants help. So I would take a look at what's happening in Deschutes County Jail. I'm not connected with all of that to know.
Isn't that what you said though to me like a month ago, that people who are coming out of jail, they're incredibly vulnerable, and instead of going right to the parole and probation meeting, they would go left and do their drugs, and then they would overdose and die.
Yeah.
Yep.
So, yeah, it's, yeah.
So I would encourage the commission, the Spanish Sheriff, take a look at that. And again, I'm not connected to the Deschutes County Jail that well, so I don't know what's happening, but if it's happening in Crook, I know it's happening even before here.
No, I know they're working with Ideal Options a lot. They just did a presentation at Behavioral Health last Friday. And actually we had them, or the Friday before, and then we had them at our meeting this week, just explained to me what they were doing. And one thing that Josh had mentioned is that if you had 7 of the shots to get you off of drugs, that could actually carry out for what, 39 months? Is that the number, Heather?
Yeah, I don't know if it's 7. I think it need to be more than 7.
We had to have 2 in the first month and then so many on top of that.
Yeah, depending on how quickly your body metabolites the drug. Yes, you could have it in just quite a while. Yeah, but Sublocade is pretty awesome in the sense that it's self-titrated. Once an individual decides that they're ready to begin, if they're ready to begin that process. Yeah. You need one.
I would just mention going back to the jail question that, when Captain Schultz and Lieutenant Gill came to present to the Board of Commissioners.
Yeah.
The agreement basically to bring ideal options in, they were very anxious about how we would perceive it, but they were also, they were very passionate about how they thought this was going to be impactful and the right thing to do, and that certainly swayed me. It's really great to hear that is bearing out, and their gamble, that they took, or the risk that they took is providing rewards.
Yeah, this isn't the first county jail that I've been involved in the MAP program for, also in Danville County in a couple of different aspects. And to be able to see the positive impacts that it has, and then conversely, the negative impacts it has when it's not available within the facility, it's very noticeable. In many different ways, so I'm sure they have a lot of very passionate things to say about that, for sure.
To go to what Brent was saying, if this is something that should be built on even more and expanded, I'm very interested in hearing what that looks like.
Right, I think we'll have some action in the legislature about that.
So any other questions for Heather? Was that wonderful? Don't you feel you're part of the team now?
Yeah, I do. Yes, I do.
Anyway, thank you so much for being here today. Tell Josh hello for me.
I will. All right. Come on.
Rimrock?
Rimrock.
Yes.
Hi, I'm Katie Cash. I'm the outpatient director at Rimrock. So just a little bit about what we do.
Oh, you might be last, but they always say the best building.
Exactly, clear. So we've been around since 1990. That's totally a typo. So yeah, it's doing that in a hurry apparently. Our flagship program is a residential treatment program located in Prineville. That program serves 12 to 17-year-old individuals, primary substance use disorder, lots of co-occurring things going on because we don't necessarily silos and mental health and SUD hang out together. That's a big pet peeve of mine. So anyway, we treat youth from all over the state in that program. Our outpatient program, we have 3 clinics, Bend, Redmond, and Prineville. Outpatient, we see really kind of through the lifespan. We're duly licensed in outpatient, so we have mental health and substance use treatment disorder licenses. We do all sorts of stuff, screening, assessment, individuals, family, couples counseling, group counseling. We have telepsychiatry in all of our locations for psych evals, medication management. In total, we have 23 QHP level counselors, including 7 co-occurring counselors. So folks that are mental health master's level clinicians that also either have a CADC, so a certified alcohol and drug counseling certificate, or they're registrants, meaning they're working toward that. That's a big philosophy piece for us at Rimrock Trails is co-occurring. We treat the whole human, do a comprehensive assessment. I don't hire counselors who say they only do mental health because I don't believe that that's a thing. Substance use disorder is in the DSM. It is a mental health disorder. And I think that's a very old school way of looking at things. Even with our family, family practitioners and our folks that specialize in working with littles, 0 to 5, 0 to 7. I still really want all of them getting a CADC because even though maybe their 6-year-old client's not actively using substances, it's likely that they've encountered a parent, sibling, someone in their life that is, and it's important for counselors to know how to address that as a family systems issue. So that's really philosophically how we work and how we hire and how we train people. We also have 6 student interns at the moment. Many of, I think 5 of the 6 are embedded in Redmond School District. So we do, we have 6 locations or 6 of the school sites where we have counselors placed on campus. So kiddos can be seen and reduce barriers, right? We help families with the paperwork process.
And just kind of trying to break down any kind of barriers to engaging or getting kiddos to a clinic with busy parents and lots of, competing needs. We have 3 peer support specialists. I know that a lot of people have talked about that, but I think that to me is one of the main things that the burn funding has given us, that we lost in 2019, our contract changed and we lost funding, and peer support roles are traditionally very difficult to sustain from a billing perspective, because so much of what they do isn't captured, right, in billable services. So for us, this is huge, because again, philosophically, like, we're all about connection, relationships, like Brooke was saying. You can be the smartest or the best, education background and gone to all these fancy schools. If you cannot connect with clients, you're not going to do good work. And peers have an innate ability to connect with people. They have lived experience. They're less scary than walking into the therapist's office, especially youth. They feel more approachable. I think oftentimes, therapists look like we're part of the system, especially if their parents are making them come, or they have trouble and they're showing up because they're avoiding consequences. Oftentimes the therapist just feels like part of that system. So our peers are just super valuable to our team, and it's been great that this funding has allowed us to bring them back. What our burn data, and then also again, kind of what the funding allowed us to do is hire the peers. One of those peers is our manager of the peers. He's a master's level clinician in SCADC 3 and also a peer. And so another thing that I think is super important is peers do really, really hard work and sometimes have the least amount of support and supervision. And so I think that was a big piece for us that we learned from prior to COVID, and when we had peers before, that we really needed to have a manager for them and someone that they could go to, for consultation and a pinch, and making sure that our peers felt supported so that they could be successful. So our peers do all sorts of stuff. They do a lot of low barrier engagement in the community. They go into the schools. They go out and interact with peers from other agencies, so that we can provide the youth piece. So, we may pair with peers from Idle Options or Best Care and go out, and if there's a kid or a youth involved, then we can kind of attach through those interactions. Our peers also do a lot of work around transitions. We know we lose clients and step up and step down, right? So if clients are getting referred to a higher level of care, we often lose them. They lose motivation. They talk themselves out of it. Beds are hard to come by, so they get fatigued and they give up. Or the other way, right? Step downs. People coming out of residential treatment, they were like, no, I've done this. I'm done. I want to go home. I don't want to do treatment. And so then they get overwhelmed quickly, and we see, rapid relapse or recidivism. So anyway, we do a lot of focus on that step up, step down piece, as well as getting people into treatment. So working with our intake team for clients that have a lot of barriers, again, if you can't pay your bills, you don't have a place to live, you don't have food for your kids, it's hard to care about your therapy goals. Right? Like those other things kind of get in the way. So super important to address those things so that people can come in and actually receive the treatment and be able to apply it. Case manager, navigator helps with all of those things. And then funding for training for CADCs, so paying for education for more of our counselors to become officially co-occurring, dual credential, whatever you want to call it. And then a little bit of statistics just about what we've served. So as far as unique clients, I kind of split it up differently. You can kind of see there my number of screenings, assessments, folks in SUD treatment and peer support, and then services provided or, encounters.
So are you saying there that you did treatment for 206 people and you did them 1,730 treatments? Is that what that's supposed to be?
So that would be, so 206 individual folks received services, 1,700 services.
Okay,
So that
gotcha.
would be peer support, therapy,
family consults, different things like that.
So how many people are actually, housed now in your Prineville location for the 12 to 17-year-olds?
Yeah, I'm not super involved with that program. So
I know it's really important though for our community, and I know you guys have had a
Yeah, it was just, obliterated by COVID and staffing and all sort. I'm not super involved, but I'm just sitting in the
Well, maybe you
meetings
can
and hear
give the
about it,
numbers
but
back to
yeah,
us.
I would say my last I heard, I think there was 8 males, being treated currently. I do know we haven't been treating females for about 2 years, and the goal is to be opening mid-November 2 females again. They've had a really hard time recruiting and retaining staff. It's residential is a tough beast, and then recruiting people to live in Prineville is rough as well, for being honest. Rural areas, really tough populations, specialty training. It's a lot of barriers. So, yeah, I guess that's the.
These statistics, is that, so on one of your earlier slides, that you serve people who are coming from all over the state?
So in res, we serve all over the state because there's so few youth residential treatment centers in the state. So I know that our residential has contracts with all the CCOs as well as lots of private insurance providers. As far as outpatient goes, we can any Pacific Source capitated CCO, lots of various private insurance. We also have contracts with Eastern Oregon, and then we also have a scholarship program. So if there's any out-of-pocket costs, co-pays, deductibles, people lose coverage and need, bridging, we have a scholarship program. People can apply and get those things for free.
I think you just had an event and it was at the same moment in time as our planning commission joint meeting. So I couldn't come to it, which is really
There'll be
unfortunate.
more. We're actually going to have, and I should probably know this, but we do have an event in Bend coming up here in February, I believe.
Okay.
So these numbers, these are outpatient services.
Yeah.
Is this like tri-county area population or?
Yeah, so our outpatient, we see most from Crook and Deschutes, some Jefferson. But yeah, I mean, as far as we do have PERN funding in Crook as well, and that, we have a small amount in outpatient. A lot of the Crook funding went to residential to help kind of restaff and rebuild that, program.
According to this, you have 0.35 million
Total
for county.
Okay, yeah.
Oh, that would be not for
For us,
Rimrock,
that's total.
that's total.
Okay. That sounds like a lot.
Yeah. So,
I'm not the money lady.
Rimrock was, I don't know, 20 or 30% of that total, but
It says here that you have 1.5 million for best care and 0.35 million for remote, according to this chart. I'm just reading the chart.
it's been over a year since I looked at that.
Yeah.
At the,
I will have to start again. I did the first and
at
then
the
there's a
Rimrock,
big.
I know the best care number's right. So it's been a while since I looked at that.
All right. Thank you.
Okay, well,
Yeah, now that we've heard the individual organization, I do have some kind of aggregate type of questions. So as we heard from your stories, PERN has been going longer on that. You're seeing results, you're providing services, you're getting to understand what kind of impact. I'm curious whether at this point you can say a feel for providing as much service to this many people, and we need to do 3 times as much, or but you have a sense of kind of the need and the overall need versus the scale of the services that are being provided, and what the difference is.
So I think, and I'll have Bear weigh in on this, a little bit. So, we just, a lot of our work, it took us a while to get the building done. Getting the building done in Bend is, challenging always. So we did, started out with a lot of mobile outreach and, while the building was getting built. And so that went off like gangbusters, working out of a van. And then you've been open properly at the Taylor Center for how long?
Probably 2 months.
And what does that look like?
It's just now starting to pick up. I've been meeting with a bunch of different agencies and trying to get referrals coming in so that people know that we're open. And so, but it's been busy. Like even coming here right now, I left the place with 1 staff, and I'm sure that when I get back, she's gonna go like you guys. But yeah, so it's starting to get real busy in there, and we've only, for the first almost year, from October of last year, we started with the van, just me and one other person. And then we eventually got 2 more people doing, so there was 4 of us doing outreach. And these numbers aren't exact, but I think we've served at 1,600 and something services and 800 and something individual unique clients. So we've reached 800 people, and then those people we met with multiple times to get to that next number.
And that's just the outreach.
And that's just outreach. That's not counting the buildings just now.
And so like, we serve 300 people a month in our patient nursing. 600 in our patient CT services. There's a lot of services happening. Our biggest bottleneck in our system in Deschutes County is our outpatient services. We can't grow counselors and find space fast enough. So even though we have rapid access into MAT, it's a 3-month wait list into our outpatient services, which is completely unacceptable. It should be within 72 hours. So that's not a burn problem. That's us fighting that qualified.
We know that one well.
Finding space, I know that Holly never has that problem, but,
Like, we don't incentivize clinicians to work with this population either, right? Like, we actually, billing codes are often less than straight mental health codes, and it's typically more work and more complicated. So I think there's just a lot of systems issues that impact that as well. Can't stay competitive pay-wise with someone going into private practice. There's lots of outpatient.
so I think, that I don't know that because of our limitations initially, most of our outreach was to the homeless, and our population we would be reaching out to is much broader than that sector. And so that's what the Taylor Center is really designed to do. And so we're hoping to reach.
To me, like your question about are we seeing capacity issues that we need to address? I think it's a little bit too early to still understand because of the workforce issues, because of the delays and how the rollout took place, because it took us all a while to get our staffing up to speed, and then we lost them again, and then we had to get it back up to speed and lost them again. So I think we're still in this moment of like seeing what the volume is.
And then I think just what I said at the beginning is, if you look at the other states in the East Coast and Ohio and Delaware and those places, it looks like we're about halfway up the curve. So I don't think the crisis has stabilized yet. And there's no evidence that Oregon will be any different than the other states.
One of the places I was going with that question was, in the discussions about Measure 110 reform, there are some folks who question whether without, if possession of small amounts of controlled substances is not a criminal offense, whether people will be motivated to go to treatment, whether you need criminalization to get
So
people
here's
to
a
go to
couple of
treatment.
things with that is Oregon had functionally decriminalized possession already because it just resulted in bench probation. And for our clients, bench probation mean nothing. So, that may be something electeds need to do to make the electorate feel happier, but I'm not sure that going back to where we were, Measure 110 would have any impact on, as far as the legalization.
And I was also just
I
trying to,
expected it to have more of an impact on the street, but what we're seeing is, especially with fentanyl, it's like, we're just not. Maybe it has some difference in how we approach people. Maybe it has some difference about the prevention efforts. Maybe it sends the wrong message. I think all those are keys. I'm a little skeptical that the legalization does have much effect. One way or the other, good or bad.
and just hearing your numbers, it seems like with Measure 110, demand for treatment and recovery services is real. I mean, there's a substantial amount.
Yeah, and so what I would say, what's clear is that we've proven that, so there's stick and carrot approaches, right? And it's not as divided up as that. But you're doing in the jail, is that stick or is that carrot? Well, that's carrot. But it looks like stick, but it's not. So what we're proving is that carrot works. We know that we're getting, because of these outreach efforts, because of the connecting with people, that's creating the referral systems into our systems. I tend to believe that you probably need both approaches at the same time. And the problem in America is we swing, we do all or nothing, we do one thing or the other, and not all of the above like we need to do. And, 40 years, I've seen the drug policy swing back and forth, both in irrational directions. So I'm the anti-ideology guy, and give me practical approaches and people who don't die.
What the consequences. So if it's a felony or if it's decriminalized, it never comes into effect when they go to get high. Oh, I'm not going to do this because it's decriminalized, or I'm not going to do this because it's a felony. They just don't care. They're just going to do it, and I'll deal with the consequences later. So more people aren't doing drugs because it's decriminalized. It's not a real thing. No one decides to do fentanyl because now it's $100 ticket. Compared to, oh, I'm not going to do it because it used to be a felony. Now it's down here. I think I'll try it. That's not how the addict brain works.
And the scary thing is what we're seeing, and maybe you guys have similar experiences, but like in our detox and our engaging people in the team, many of the clients express great fear for the drug, but still find it impossible not to go back. And I've really never seen that. It was always like some, with math and Carolyn, it's like the glamorization of what they're doing. The old A saying this and alcohol, so the person can be laying it together and down with the world. And with fentanyl addicts, they're afraid, but they still feel compelled to go back to it. And So,
A measure of that and a measure of an absolute fear of the withdrawal. An absolute, like more so, you see the fear of the withdrawal with the heroin and the other opiates. The fear of the withdrawal for the fentanyl, I think is far worse than any other fear that's,
but the dependency levels are so much higher than.
and so much faster.
And then locally, we're seeing some designer opiates built into the fentanyl. They're showing up that are more potent. You see them now and that, but it's not so much xylazine, but right.
I'm not sure if I've heard that and now it's so far.
Yeah, that's our doctors saying that out of detox.
We had a couple of cases in Redmond a week ago, because I just was talking to an RN who said they had some drugs that would not respond to Narcan.
Right.
It was absolutely frightening. And yeah, so it's here. It's, it's
Yeah.
only going to get worse.
Right. And, it is a perfect drug for drug cartels.
Yeah.
You don't have to deal with farmers anymore and growing opiates, and it's really easy to smuggle through and easily made, and China supplies all the precursor chemicals. And China's not going to slow that down. It's great.
I think the one thing, just to kind of play an opposing side, super quick to what you guys are saying is, the reduction in attendance across the board in, some of the more effective programs that we had, like our, well, I just exited my whole brain for drug treatment. So
Drug court?
the drug courts, thank you. Drug treatment, hello, Heather, that's where we are, thank you. So drug court treatments, the reduction in enrollment in those programs, those are really effective programs, and we've one here, even is closed down.
Right. It just closed.
Yeah, and the enrollment across the board, I've seen in many, many programs has been at all time lows, like 4 and 5 individuals in a female and male program.
The one in Deschutes County was struggling longer for measure one thing.
Yeah.
Yeah, and I mean, to be clear, I think we've kind of gotten to the bottom of, it's not decriminalization of small amounts, possession of small amounts of substances that has starved the Deschutes
Yeah.
adult treatment court of cases to
Sure.
work through. It's, there were workforce challenges, there were partnership, treatment provider challenges. And also, I mean, I've written a book about child protective services, our drug treatment court, I'm beginning to understand the nuances, because it was pretty different than all of the other ones around the state. It really depended on many partners, including Department of Justice Services,
Yeah.
who was also having workforce shortages, who was also not able to hold up their role in providing the complete wraparound services that make it part of it. And that's
More so.
that's another piece,
Yeah.
so lining up all these investments, all these partners, and keeping it all together to be able to deliver this resource-intensive product,
Mhm.
the service that was, 70% a success rate for our drug treatment work. But it just takes a lot of resources and a lot of partners, and it's hard to hold that together over time.
Yeah.
We'll be asking the legislature for help in supporting that model and bringing it back.
We've been able to keep it alive. Those guys. Yeah.
Rick, could you have said that louder, please?
Sure, we've been able to keep, our specialty, we call it specialty court in both Crook and Jefferson. So we've been able to keep those going and vital. So each county looks a little bit.
But really importantly, I mean,
Big changes, so.
people were ending up in drug treatment court, not because of possession of small amounts of controlled substances, but it was the crime that they committed that was egregious enough to get them into the criminal justice system. And then the judge would determine, well, I think that your criminogenic behavior is really tied to being, your addiction. So you're a good candidate for being rehabilitated by the drug treatment.
Yeah, so we did local drug court did a big change in our when we first started it. There was a family drug court that was really just aimed at women and children in DHS custody, all that. And then the research became stronger when higher criminogenic factors would be the target population for drug court. That's when Hinge was years ago we became local. And so and that's when Best Care stopped being involved. That wasn't really our wheelhouse, our best lane. And so so that's sort of the difference. I'm a big supporter of drug courts. I was on the advisory committee to get them involved and get going in the state. So, but they only train a small population.
Yeah, it's very,
Specialized, and then you have
But I think that speaks to the continuum that we've talked about.
Yeah.
Like, there's a whole range is required in order to treat this
Yeah,
population.
that's what I would say. I think it's all hands on deck point of time right now, and not to one or the other.
Which gets to I had two more questions. One was essentially, so I asked about kind of scale, like are we meeting demand for service with the capacity that we have? But and I got a good feel on that, but are there any gaps? So you all are providing care and services in specific niches. Is there a population or a service approach that is missing in our community?
I will say that in the state of Oregon, youth services for substance use disorder is at a near state of collapse. And Rimrock Trail barely been hanging on, and they're one of the few. A number of programs across the state have shut down. It's really, I've watched some really heroic work to keep that program going and vital. I think the Latino services in the state have not reopened the sole residential treatment program for Latinos 22 years ago. And it's January 1st, and we still have the same 12 beds. Latino population has doubled. And they're only for males. And generation later, we need residential treatment for women. The outpatient system across the state for Latinos is arguably weaker than it was 20 years ago. So you want to point to a definition of institutional racism where nobody's racist, but the result is racist. This is a pretty classic example. And then I would just make a pitch toward we need to have a real focus on pregnant women. And I think the payoffs for that are huge, dramatic. And so I would even say we have a Nurture Oregon grant that gets refunded, and we sweat it every 2 years. It needs to be a system of care across all counties. And it's proven itself. We have the data, the statewide data showed in the 8 counties it's in. So we point to those places. Yeah, I'm sure I'm listening.
No, I would just toss in Petrie.
Right. Well, I think that it's beginning to blow up in the youth population.
I would also. Did you have another question?
I'll also say that I see the gap in Deschutes County when it comes to the geriatric population.
Yeah.
Yeah. Yep, there is, you know, coverage with, for treatment services with people who are on Medicare is basically non-existent.
Yeah, my one other question is, so we are living in the moment of Measure 110 reform policy discussions. And, you know, we heard today about really important services that are being provided in our community. I'm curious if any of you all have thoughts on how, as we work through Measure 110 reform, you know, discussions, how we maintain the important services that that you all are providing that are being offered through the burn.
I gave testimony the last Wednesday to the committee at the legislature. And I voted for that.
I think I may have read it in the paper.
Yeah, there was a summary was in the paper, yeah.
And I believe one of the points was, you know, whatever you do about criminalization or decriminalization, the burn funding is having an impact and is successful. So
Right.
keep that.
Thank you. You can see that from the group of people here today, that the money is being put to good use. A lot of people are being served, a lot of lives are being saved, and we're supposed to be able to continue doing that.
For
Thank you for
sharing that
having
story with us.
Thanks,
Great,
everybody.
thank you, everyone. Okay, that was only double the amount of time allocated, so we must have been doing a good job. Thanks, everyone.
Sure.
Item number 2 on our agenda.
Yeah.
Jen.
Talks about new staff reports, it's just minor changes.
We covered some COVID, yeah, so we got to the
And you don't want to sit right underneath that.
Yeah.
Okay, did you guys hear the message? Yeah,
Yeah, I know the hard way of that.
yeah, it's not a pretty place to sit.
And is this different than, is this different than the one that was? Unfortunately, I put them both down next to each other and I can't remember which one you just, I see, this one's increased, so this is the new one. Oh, this is old. But that's the one.
Okay, good afternoon, Jen Patterson, Strategic Initiatives Manager for the record. We're here to do fiscal year 23 Q4 and fiscal year 24 Q1 staff report, performance measure updates. We have 5 departments gonna give us some quick updates. Real quick, the staff report that's different is the first objective under the clerk's office. The actual update measure was taken from a different measure. So I've just corrected that so that the reporting in the new update staff report is the correct one. And then I also inadvertently left Kevin Moriarty top of the list of attendance spot. He's now added back in. So with that, we're going to start with our county clerk, Steve Dennison, who's going to come and give his.
Where do you want to sit?
Yeah. You can come up here.
I would sit just over there. Yeah, you don't want to sit where you were.
If you see this one, then I can actually almost see you. No, I can't.
Haven't been in here for this configuration, so. All right, Steve Dennison, county clerk, and yeah, this is a little bit different with the chambers downstairs. Discussing a couple of our performance measures. As Jen mentioned, the first one is to support and promote Deschutes County customer service every time standards, and we do that by measuring election personnel in cost comparison for 1,000 ballots tallied for countywide elections. Our target value on that is it was $419 for comparing personnel costs, so people hours, and that average that $419 is taken from the average cost over the last 15 years for elections. And our actual for this last.
Sorry, can I interrupt real quick?
Is that the right one?
So when we talked this morning, I inversed it. I thought it went the other way. So go refer back to your first one.
The one that I just texted.
Yeah, and the actual values in the first one is going to be correct. Sorry, I thought it was the opposite way.
That's right. Okay, sorry.
I can see the looks of
Yeah,
confusion all of
nobody
a
knew what I was
sudden.
talking
Yeah.
about. Okay. So I want this one back.
Yeah, you want that. So what is gonna be incorrect in this new one, and I will correct it and enter into the record, but the service delivery measure is stated incorrectly, but the original one, the values are correct. Sorry.
All right, take it from the top, but yeah, I think you get it. So we're comparing, election personnel, so the cost, divided by 1,000 ballots for each countywide election. Again, that $419 target was the average over the last 15 years, for countywide elections. And this last May, we came in at $251. So easily met that. And we do that, if you compare this and look at our measures over time, where this really changed, was when the county went to, Nancy had purchased a new voting tabulation system, clear ballot. There's a lot less, processing, a manual processing at the board tables. It's done, on the computer now, so it's a lot more efficient. Also moving away from having secrecy sleeves, in the ballot, packet, cuts down on some processing time. So we're pretty efficient, as far as people hours go in elections. Any questions about that one? And then our second one, we have this one right, is comparing our FTE to like other size counties, FTE to registered voters. So we're comparing to Clackamas, Lane, Jackson, and Marion counties. And over the last few years, and reported in previous meetings like this, we were by far doing the most work on our registered voter roll. Any other like counties, that's flipped a little bit since the board approved our one increase in FTE. And now that puts us right in the middle of the pack for FTE to registered voter totals. We're still doing quite a bit with littler, smaller resources than some of the other counties, but and again, this is due to efficiencies with technology, best practices, and that experience. Gonna do 2 to 3 minutes. Any questions about either one of those?
I know I told you the secrecy sleeve, you could tell who I voted for without that this year if you held it, Anyway, maybe I was only one of 5 people, but I really, that bothered me.
So voters are welcome to conceal their ballot or fold their ballot, however they choose. The secrecy sleeve, we're one of 32 counties that decided to go away from that. We still have the privacy weave on the inside of that envelope. And then as you return your ballot is going into trusted chain of custody hands. Drop it in the drop box, it's coming into our hands. We put it in the mail, it's the USPS that is a trusted partner.
So you can actually take another piece of paper and wrap it around if you want to.
You certainly can, yeah. Or
And it won't-
take a page out of the voter's pamphlet that every voter is provided and wrap it up, and then it will still be processed in the
Okay.
same manner.
It will not be thrown away.
It will not be thrown away. We don't throw anything away. Okay.
Thank you.
Thanks.
Yeah, no, I'll get that
Yeah,
corrected.
yeah.
Thanks. Good luck tomorrow.
Okay, thanks.
All right.
What's
next-
tomorrow?
Next.
Oh, God.
Like, what is, it's Halloween.
My mind is all over
I'm like, what am I missing? Yes, it's Halloween. Okay.
Good luck with Halloween.
Well,
We know you got those 2 kids.
all right, next up, we have Dan Islor. Okay, next we have Dan Emerson from Finance.
Afternoon, Commissioners, Dan Emerson, Financial Planning and Budget Manager. Here. Our finance objective is service delivery, maintaining strong fiscal practices to support short and long-term county needs. The performance measure is coordinate with the Board of County Commissioners to distribute ARPA and other consistent updates to the community on the investment of ARPA funds. And should be relatively short. As you know, on 8/23, we, Board of County Commissioners allocated the remainder of all of our $38.4 million approximately in ARPA funds. So we just put this visual together to kind of briefly touch base on what we funded, about $10 million, a little over $10 million in homelessness for the community, $7.8 million for affordable housing support, $5 million creating new childcare or revamping existing childcare to be able to support more individuals, $4 million for public health, COVID unit team, contact tracing, COVID testing, $3.7 million for food assistance with our community, $3 million of infrastructure, water, sewer, broadband for our community as well, $2.5 million to the small business through COIC, where we give $2.5 million to those financially impacted after assessing tax statements. And of course, $455,000 for behavioral health, mental health case management. And then there's some administrative costs and some other nonprofits at the bottom that we've allocated funds to. So really impressive allocation of funds, all of them ARPA eligible, very much in line with the ARPA policy and the American Rescue Plan Act. So it's been pretty incredible. Sportsmen to be a part of it. Question?
A lot of this allocation work a long time ago, so it's always fun to be, or it's fulfilling to be reminded of all the great places that we allocated these funds. Thanks for this new visual. It's really helpful.
Of course. And as we come to the conclusion of this, I've heard from commissioners that we might want to do some kind of media just to remind folks of all the great work that we've done, all the funds we've allocated to partners, sub-recipients within the community.
So Dan, I see here we spent on the total sewer that's the actual number then, the 148,000?
Believe so.
Right. Okay.
I think it'd be great for us to do some in-depth communications work around these investments.
A lot of counties, as we've talked about, a lot of counties just reimburse themselves out of their general fund or something like that. We really did put all of the money practically back into the community, about $37 million plus kind of back into the community or towards health services, COVID unit team, which was working within the community, contract chasing, doing isolation, and all those things. So pretty impressive.
We noticed we didn't do anything for the Sisters Rodeo Association. They do so much for the community. And I did just hear that the red section at the rodeo grounds desperately needs to be upgraded. So I know we don't have any money left here, but I did want to mention it to the group that, yeah, if you've ever sat, don't get your tickets in the red section, guys, because I need, or at least, they need to upgrade those seats sooner rather than later. Yeah, they were asking just for 100,000 from us, and we didn't give them anything.
They were pointed to the business assistance grant program and they put in an application.
I'd have to review if we had 300 plus applicants. I'd have to review if they put in an application. I think we had 100 some odd folks that ended up being eligible. And again, we did work in collaboration with COIC and reviewed every one of those entities' financial reports to see if they demonstrated their revenue or expenditure loss off of their average prior to COVID-19. So, I could see if they put in for the small business grant, if they weren't.
Well, those grants they weren't 100,000.
Some of them are.
I didn't start, wasn't like 82,000 or something the most that was granted?
I would have to review. I think we did a slope. We certainly, some people were eligible for much more than the funds that we had available. And we allocated 2.5 million over 100 and some odd recipients. So we just weren't able to allocate from the losses that were built in the business community. But certainly they're more than welcome to put in an application. We don't have our book funding at this point in time.
Right, we don't.
Right.
And they couldn't get it started probably in time. We did find anything. So is everything else that we believe has been asked for going ahead? Is there anything that's on the fence that might not happen?
Not that we're so far, all the construction capital projects are looking like they're going forward and will be done by fiscal year 26, or by the end of calendar year 26, which is the ARPA deadline. And then of course, as we talked to you, we'll be moving the COBO and the veterans
Right, it's gonna be changed.
over. Yeah. But I don't believe that we have any more ARPA that are going to be considered coming back to us, or we're at risk of coming back to us at this point in time.
On neighbor impact, did we do the 2.4 million initially, or did we do like 2.2 and then we added another 200,000? Is that right?
I think we did 2 million initially, and then added 400,000 for the food.
Right. Right. Okay, so I'll look at my notes.
Sure.
Thank you.
Thank you.
Next up, we have Kathleen from Human Resources. Kathleen Penman, HR Director for the record. And I've been asked to talk about one of our performance measures. And it is, let's see, the performance measure itself is where we are looking at the comparison of the percentage of directors, managers, and supervisors in county workforce in relationship to the percentage in the community population, and specifically for women and minorities. And we actually have two performance measures that this one is specifically looking at the percentage of directors, managers, and supervisors. And we do have another one that actually looks generally at the county workforce as a whole. These performance measures we actually worked with our prior auditor as we evaluated some of the audit recommendations that have come out of series of audits. And we wanted to sort of track, benchmark where the county is in these areas. So this was actually really an effort to start just tracking and benchmarking where we are. And so this is the second year we've been doing that. In reference to 2023, we did have we were actually looking pretty good in this particular one, in both the, when we looked at both females and minorities, we were hitting at about target to the community. We did see interestingly enough, we saw an increase in the number of minorities represented in that area. Not quite to community level yet. That was at 8%. We're sitting at around 7%. However, we did see a drop in minorities, females, excuse me, and the director, manager, and supervisor level. So a little bit of a decline there. And we're looking at trying to find out exactly sort of why that is, or where we can point that to. Change, it's not a huge population, so change in one or two in that particular area could really impact those numbers. A couple of things as to what we're doing to address that. One is that when we do look at things like promoting from within, that means we have to have a diverse base in order to promote within. So as we see the efforts increasing in that area and that benchmark, that is helping us in terms of providing additional opportunities for both minorities and females in that area. The other one is that really pushing departments to consider an external opportunity. Internals can be, supported in applying, but when we open our recruitments out to the public and the external, we really can bring people in at that level from the community, ideally from a more diverse demographic. The other area that we're working on to impact this one is we have been working with a couple of different advertising programs that look at different areas to advertise and market to go and find folks who do that work. One example, for instance, is that when we posted, this was actually a little while ago, but it's a really good one, it's when we posted for the, IT director, we actually, we pointed specifically to females in, technology to be able to recruit from that. Interestingly enough, that is not where we got our current IT director, but, we cast that nice and broad. So, those are some of the areas that we're working on to specifically address these pieces. We'll also say that currently, the reporting in Munis that we use, it's called the EEOC reporting, Employment Opportunity Commission report is broken, and they are now fixing it, which is giving us, this is my positive spin on it, an opportunity to reevaluate how each position is identified in the system. So we're actually also benchmarking against other organizations to see, are we identifying directors, managers, and supervisors the same as they are. So we're kind of looking at apples and apples there. So that's an update on the performance, that particular performance measure, kind of why it came about and how we're looking to impact it. Happy to answer any questions.
Can I just ask one question?
Sure, you may.
Do the, what we talk about department heads, does that include elected officials? Something that where it's not our hiring practice, that's the voters hiring practice, or is it just limited to? And I just,
Yeah. So, I think that's a good question. I think that it, I don't actually know if it includes the elected officials in there. I know that we have, my notes in here indicate directors, managers, and supervisors.
Okay.
I have a feeling it would have said elected officials as well, in that particular piece, but I can definitely clarify that.
yeah, thank you. I was just curious
Yeah.
because I just did, as you started talking about it, just the light bulb went on and I thought health services, George to Janice. I thought about community justice. Was it to
DV, yeah.
DV.
And then don't forget Dave
Ken
Gibbons has retired and Joe Sidoni retired.
Yeah.
So, yeah, so those four right there, like, yeah, flipped.
It is, right, and keep in mind that this includes managers.
Yes, I saw that. And
So that-
supervisors.
Right, so that is pretty big. And, in talking to some organizations some of our divisions who've been interested in saying, we really like to see more diversity in, our leadership. And we've talked about, okay, well, how long does it take to get from line staff to leadership in 10 years? Okay, well, if you hire someone in line staff that's diverse in about 10 years, then your leadership will be diverse, unless we seek external competition there for. So just some conversations with departments to continue to kind of look at practices and how we can adjust for those. Okay, thank you.
Thank you. Right, next up we have Ann and Kilty and Aaron Moore from Health Services.
Hi, everyone.
Well, you've had a fun afternoon.
Ann Kilty, Program Manager in Public Health.
I'm Erin Hoare, and I've coordinated our perinatal care.
So we are here today to report out on our metric of assuring 90% of pregnant women being served by Deschutes County Health Services are receiving prenatal care beginning in the first trimester. And I just want to add that actually our metric for first quarter of this fiscal year is not 85%, it's 96%. There was a error in calculation, so I'm happy to report in that direction instead of 85%.
On this one, it says 95.23.
So there's some, it turns out that in the place where you enter the data, sometimes people from other departments enter it in the wrong
So
spot.
accidentally entered.
So that actually is a communicable disease one, and this is where this happened. So
We've all been fixed.
you can't log in when you enter it.
So the actual
Actual
is
is 96%.
96.
For Q1, and it was 89% for Q1. And while various teams contribute to this, reaching this goal, like the reproductive health clinics, WIC, and nursing home visitors, ultimately the heavy load of this is done by the perinatal care coordinator. So we've talked about numerous times here. It's a really important metric. We know that when individuals enter into prenatal care early, they have earlier screenings for maternal morbidity such as diabetes, hypertension, infections with sexual consequences, substance use disorders, maternal mental health disorders, decreased pregnancy and postpartum maternal smoking also, it was early prenatal care, increased infant well visits after delivery, and then increased positive effects of breastfeeding, and there are a number of health benefits to early breastfeeding. And not included in this metric, but also really important, is individuals who we have first contacted in their second, third trimester. And the standard that PCC has been working towards is to get these individuals in their prenatal care within 2 weeks of the first contact with Deschutes County Services. And we are one of 11 Oregon counties with above 85% of individuals being engaged in early prenatal care, which we're pretty proud of. Any questions about?
So a couple years ago, I'd heard that women that were pregnant were smoking marijuana. And at the time I thought, oh my gosh, do they not understand what they're doing? But then when I'm now hearing that we've had, you know, the 6 fentanyl babies in the last 70 days. What are you guys seeing where you're with your team?
Yeah, it's heartbreaking.
Yeah.
And it's addiction is a sad, hard thing. There's a lot of stigma, like we've heard earlier in the presentation, around people during pregnancy and postpartum who are using. And so I love this community and how closely we all work together. I think it's all about relationships, whether it's with the client that you're working with and the safety you bring to them in accessing care. And that's what our program really looks at. And then the relationships we have with the providers. And then we work really closely with the moms program. We meet weekly. We do case conferences to help check in with clients. Are we working together? We're on speed dial for them. They're on speed dial for us.
But see, to me, it's like people have lost their way.
Absolutely.
You guys, they have lost their way. This is so huge. I wouldn't have dared done anything like that. And I talked to my friends and they were all like going, what has happened to our society? You know, it just seems like
Such a complicated problem.
Right, it's so complicated, but I'm just saying, we have really lost our way.
Yeah.
And how can your program overcome the wave?
Right.
Well, I mean, I think that, you know, our focus is fairly narrow in terms of the larger problem of substance abuse. This particular, our teams, the nurse on busy team, the perinatal care coordinators, like this is kind of an intervention specifically with the perinatal care coordinators, getting people into services as soon as we're aware of them, and as soon as we know they have a problem. You know, obviously, we can't address that problem. That's not our skill set, but getting people into the services with people who can address those issues, that's where the highest value is for what we can do with this team.
And it's so
It's great to
complex.
have just heard about the moms program and then hear you guys talking about referrals.
Yeah, more support. The housing unit that they have is wonderful that they have that. It's a huge relapse time. It's right after you have your baby. It's the biggest relapse time.
So how big is
safe
that?
Housing. What?
I mean, how big is that housing?
Not very big, and we
Right.
lost our other one, Dawn's house.
Yeah,
No
Dawn's house.
longer.
What happened to Dawn's house, by the
I
way?
don't have the information on that.
Nobody seems to know what
Yeah.
happened to it.
So I think housing is a big one, but it's very complex and we are a piece of the puzzle and provide a safe place for access to services that can further support. And we really partner in that wraparound. We can help with, you know, WIC enrollment and some of those other things, nurse education, right? Nurses coming to partner with them and help teach the parents at lower stress levels. So our piece is what can we do to lower the stress level of that person and support them getting access or the tools to get access.
Also, these trusted relationships with the perinatal care coordinators and the home visiting nurses, like from Babies First, who will start during pregnancy, those trusting relationships then allow women to sometimes say that they're struggling, where they might not feel like they could say that in different circumstances.
Yeah.
So then we can help get them into services that way also.
And now with Family Connects, everybody gets to visit the nurse after the baby born.
If you wanted.
If they want.
If you want it, yeah, it's not mandatory, but boy.
I know it's a requirement of the insurance, right?
No,
No,
of the
it's not a
legislature,
requirement?
of the legislature, not of the
Yeah.
insurance.
Well, Okay, but then it goes into your insurance policy, so that,
So that's another great option that we have.
Yeah, we didn't, community economics to, sign up for this business. That's a really great support for people at this high risk relapse time.
Any questions?
No, that's great. Thanks for your support.
Thank you.
Or
All right, and last but not least, we have Kevin Moriarty, our county forester, to report out the measure.
Good afternoon. For the record, I'm Kevin Moriarty, County Forester. I'm reporting on the performance measure of maintaining or increasing the number of communities participating in the Firewise USA program. So when I first entered this number, we put 61. And I need to explain this just a little bit as far as how these are tracked in Firewise communities. So Firewise communities are set up through the Oregon Department of Forestry, at least in Oregon. They're the ones who do all the application process. And then during that process, they assign coordinators to each one of those communities. We have been assigned, or at least at that time, had assigned 62 communities. But what I have found out is that for some reason, and I don't quite understand this, is that those aren't all the Firewise communities. There's actually a total of 68 active Firewise communities, but for some reason, all of them weren't assigned to us as Deschutes County. So the more accurate number, I guess, as of today is 68 active Firewise communities and 73 pending Firewise communities.
oh my gosh, we just jumped up then.
Yeah.
It's great.
We just jumped up, and I just would like to reiterate that these numbers do fluctuate a little bit. Anyone that's active can become inactive if they don't follow their yearly requirements. And then also the pending communities as well don't necessarily become active. If for some reason they don't follow the procedures, they can drop off as a pending community. So there is a little discrepancy in what we see as numbers and what there actually is out there, but I just want to at least clarify that.
the 73 and the 68 are separate, where the 73 includes the 68 plus a few pending.
So 68 is the ones that we currently have active. I believe there's one inactive because I think we've been up to 69 at one point. There's one inactive, and then 73 includes all the ones that are pending or inactive. So we have 73 that are, like, the only two other categories would be inactive or pending. So we do have a fair amount. Yeah.
When they're still doing work in those communities, even if they're only.
Yeah. Yeah, and I guess I would like to say what a really good measure is, and looking at this, at least from Deschutes County's standpoint, is how many communities we funded in the last year. And at least since I've been here, we've funded 53 of those 68 communities with total funding of $270,000. So that's something I'd like to track, and I think that's something that we should definitely include when we describe these performance measures. 53 communities, funded 53 communities through those last 3 rounds of grant funding, at a total of $270,000.
I was speaking this morning with the commissioner just about the staff resources that it requires to develop the agreements and monitor the work. And how does it feel with your staffing levels, with the number of communities you have and the work that's happening?
Yeah, we're not necessarily having a funding issue, maybe as other departments. We're having a capacity issue, trying to keep this program and others with only 2 people on our staff. Very difficult, to say the least. I have spoken with Eric about it, and others have particularly trying to increase our staff in the next year. We do have a pretty sizable contingency that we could at least provide for a short-term full-time employee looking for.
Thank you, I was just
Or
curious.
do things like contract with COIC for CWPP updating and things like that.
Yeah, or contracting out big heavy lifts.
Yeah, it's great that we're doing so much work in this area, but the capacity does become an issue. And as we've talked about, there's a lot of contract administration and
Yeah.
coordination and inspection and yeah, which is great. Good. It's all good work. We just want to make sure that
Yeah.
we continue to be successful.
Yeah.
Thank you.
Excellent. Thank you, Kevin.
Okay.
Thank you. That is it. For performance measures will come back in January with Q2. Unless there's any other questions with this.
Thanks.
Okay,
All right, thank you.
thanks, Jen. So one of these we can just throw away.
Yes. I will send it, I'll update it and send it around just so you have it for the record.
So maybe,
Okay.
okay, any other items?
Thank you for the day.
Thank you.
Well, thank goodness we found the county college forms. That person. Anyway, yes, all those, hopefully everybody's name was spelled right. And we get county college graduation tonight, what, at 6 p.m.?
They'll be downstairs at 6 p.m. and then they'll head up to the clerk's office to hear from Steve and his team.
About the election tomorrow, right?
Or maybe next week, but yes.
Okay, that sounds like a win-win. Anything else? Are we good? No executive today, but on Wednesday, right? I think I saw that. Okay, the meeting then is adjourned. Thank you all.